Right. So welcome to Way to Paces, one of the free sessions. This is about legal and ethical issues in MRCP PACES exam. I would like to share a slide. Right, hope you all can see the slideshow. And then we'll start. Right, this session is about legal and ethical issues for MRCP PACES exam.
Way to Paces, the right way.
So with the legal issues, we want to know more about the legal framework, first of all, in terms of knowledge base. Then once we know what's going on, we can apply the knowledge practically in each and every scenario. So the topics we are going to touch on are the list here. So first of all, the mental capacity. So mental capacity is very, very important in terms of assessing the mental capacity as well as application of mental capacity in each and every scenario. When we talk about mental capacity, I'll just follow a few more slides to explain more in detail. This is just to say, in terms of, let's say it's between a doctor and a patient relationship and the consultation. So patients come up with a complaint and then the doctors will assess. And based upon the assessment, we suggest a treatment. And that's where checking the understanding of the patient and then discussing together a management plan, which is okay for the patient. So that's where we need to assess the mental capacity. Whenever we say anything, communication skills, the key part is we tell someone, and then whether the message has reached someone else, we need to check. And the best way to check the understanding and then go with the flow. The next thing is about deprivation of liberty safeguards. Again, when patients lack mental capacity, they can't make a decision. And the medical team, or we, the doctors, make decisions on their behalf as a best interest decision. And to make them, let's say they're coming to the hospital and then they are confused and they want to go home. But ideally speaking, they can't go home because it's unsafe and the treatment is absolutely necessary. And because they are confused, they are telling us they want to go home. So in those situations, how to make people stay in the hospital? Again, we need to apply for deprivation of liberty safeguards, and that allows us to keep people in the hospital for valid reasons. And again, it's the same as the best interest decision. Best interest decision will come into play. It's not what's best we think, it's what's best for the patient. And we need to discuss with the family and most important people related to the patient. Next thing is confidentiality and breach. See, confidentiality, we all know, we are not allowed to share things. And then because the confidentiality is a big issue there, and we need to follow, it's one of the things is a legal framework. And I put the legal framework and ethical framework because legal is definitely we need to follow that. For example, we can't discuss in the corridor with the patient's name and patient details. And let's say we see some patients in the hospital, very well known in the community. So we are not allowed to come out and leak about the patient details or anything, even within the same family. It's highly confidential. And that's where we tell the patient in terms of history taking, particularly sensitive issues with the personal issues, as well as like a sexual history and all. We will say to them, this is highly confidential, and then we'll keep within ourselves. It will be in the notes and won't be shared to anyone else. And the bit we talk about confidentiality, that promotes the trust between a doctor and the patient, actually, mainly. Otherwise, they won't tell us anything. And that's true with any circumstances, any situation where the relationship between patient and the doctors actually. Having said that, in some of the situations, the confidentiality can be breached. There is a clause in the legal framework that the confidentiality can be breached in public interest and also certain situations. So I put I've not discussed in detail about the scenarios or situations here, but just give an example. Let's say driving regulations or informing DVLA. You get a patient with a seizure, and they're not the first time, let's say 3-4 times, and even the first time, and the patient's profession is a driver or the driving instructor. So in that case, where do we stand? Do we need to inform the DVLA about the seizure, and do we need to get permission from the patient to inform the DVLA or not? That's a big question, and that's one of the common stations we encounter in this exam. So in this situation, we can divide different things. If you are talking only about the confidentiality, yes, unless the patient says to share information to people, we are not allowed to share, and that's what we said about confidentiality. But here is a personal confidentiality, and then what is with the public interest? So if we didn't tell the DVLA and then allow that person to drive on the road, it's a big disaster for that patient, risking his life in case if he met up with an accident, and also with the other people. So individually, yes, there is a confidentiality issue. We are not allowed to tell to anyone unless they're absolutely necessary, and we are not allowed to breach unless the law says with some circumstances. So in this case or in this scenario, we have to disclose that to DVLA, but we can tell the patient that we are going to disclose to DVLA. It's not like we are not telling the patient and like working behind the back or under the table to inform the DVLA. So we need to tell them, explain everything. Yes, I can understand that's your main job, and then we'll talk about the other things, what else we can do to help your job and support you. That's a different one, but it's because it's detrimental for you to drive on the road with the seizure. When you had the seizure, that's not allowed, and also for the other people. So we need to explain that. And the patient is, ideally speaking, the patient by themselves can inform the DVLA. But after a few suggestions, if the patient is not doing or hesitant and having, as I said, the recurrent seizure, recurrent hospital admissions with the driving instructor job, we have to tell the DVLA. We will inform the patient. Yes, we have to tell the DVLA. And that's where the breach of confidentiality. Informed consent. So when I say consent and informed consent, see, with the consent, the verbal consent is okay. You just ask the patient, is that okay to do this? And patient say yes, and then you will do it. Say implied consent is what we say. For example, if you're going to take a blood sample and then you say to the patient, I'm going to take a blood sample, is that okay? And people with the full consent show their hands or like a cubital fossa to take the bloods. That means implied consent. Patient said yes, unless the patient is saying yes, he or she won't be able to show your hand and then allow you to take some bloods. That's it, implied consent. Informed consent is anything we do. We need to explain the pros and cons and plus and minus and available options, and then tell them why we are going for this option without coercion. So when I say without coercion, and not putting pressure on them, not influencing, we can tell our suggestion as a professional point, but at the same time, we have to tell the positive and negative in any procedures, right from OGD, and then let's say giving blood transfusion and starting people on morphine, anything. And this is one of the commonest stations as well in terms of counseling or taking the consent for any procedures like say a BG or anything like doing a steroid injection in the shoulder, anything. So for that, informed consent, we need to know as a knowledge base about the procedure and why we are doing, what are the benefits, what are the harmful effects, and then we need to make a decision in terms of getting the patient, okay, these are all the things, so now you can decide, and then let me know, is it okay to carry on? That's how it is, whether it's like a procedure or anything, we give a medications or anything, that's where the informed consent means. If you're not giving enough options for the people to think or the people to decide, then that doesn't mean that's an informed consent. Now, coming to this, like informed consent and linking to mental capacity, say I said the mental capacity is the key in whatever situations we deal with. See, let's say the informed consent, we are taking consent and the patient doesn't have capacity or lacks capacity. That's a completely different issue. And how do you check the mental capacity? Again, with the consent, you have to repeat again, ask the patient to tell me, okay, we have discussed this, and can you please tell me what is happening? And that is where in station 4, communication skills, we have to have a break and then check the understanding then and there. And not only in station 4, communication skills, also in history taking or examination. Whenever we give any information, we have to check whether that information has gone through and whether the patient understood that information in small chunks. That's how the whole, like a consultation or the station should be in any station. That's where there is a link between the consent and mental capacity very strongly. Driving regulations. Again, there are certain regulations in terms of the patient has, let's say, I'm not going to tell you the entire regulation in terms of, okay, they shouldn't be driving for 1 year, they should be driving for 6 months or 3 months. You can whisk through all those things. But what I'm trying to say is, when there is a law stating there is a particular regulations in this condition, you have to tell the DVLA and they're not allowed to drive with this, then that should be followed 100%. There's no leeway in it because it's a law. When there is a red signal, you have to stop. If you don't stop, you will know what will happen. So likewise, when the speed limit is 40 or 70, like in the UK, 40 miles or 70 miles per hour, you have to go with that. If you exceed the speed, you know what will happen. So that's where the legal framework comes from. Whenever there is a legal framework, there is no choice. We have to do it. We are bound. As a doctor, as a medical team, we are bound to follow the legal thing. And also some legalities in the law applies to main public as well. Next is the post-mortem examination. See, again, post-mortem examination, there are in some cases is a legal requirement. Let's say communicable disease, we have to inform, like let the information know about the communicable disease, and also like industrial exposure, like a mesothelioma, we have to discuss with the coroner for the possible post-mortem examination, and with the sudden unexplained death, we don't know the cause, we have to let the coroners know and then involve the post-mortem examination. So these are the things which come under legal framework because there isn't any leeway. There's no option. There's no second thought. Can we do this? Can we do that? No. If the patient has mental capacity, we need to assess and then they will decide what they want to do and they can refuse the treatment. Deprivation of liberty safeguard, the second point. Again, if the patient lacks capacity, if you want to transfer anyone from, let's say, hospital to nursing home or home to hospital or hospice as well, we need to do like a DoLS application, retain people in the premises against their wishes if they lack mental capacity. Confidentiality, yes, there is a legality. If we breach the confidentiality normally or without any reasons, without any important clauses, we will be getting into trouble. But there are clauses where we can breach. We need to be confident about those and discuss with the team. Consent, as I said, it has to be informed. You can't just and say, okay, I'll give you the treatment and then leave it. Anything, I would say, let's say prescription of morphine. If you're going to give someone morphine, you have to tell the possible effects, benefits, possible side effects, and then discuss. If you're planning to give anyone steroids, yes, you need to explain the side effects as well. Because let's say we have not informed anyone and you just say steroid will help in this, and then they had a psychotic episode and then insomnia and lots of problems with the steroids, or let's say severe sickness and hallucinations and drowsiness, sleepiness with morphine, opioids, we have not told them, and they can ask us in terms of, you didn't tell me what are the reasons and what are the side effects, and I took it for granted, and that's where the informed consent is. And as for the UK regulations, there is a formulary called BNF, British National Formulary. So that's about all the drugs and medications and what the side effects and like renal impairment, do we need to do anything, or hepatic impairment. So everything is there. So the reason I'm telling you this is, say, let's say you are going to tell about the side effects of a drug in that framework. It's a book, British National Formulary, or it's available online as well. It will show like the most common side effect, less common, rare, very rare, something like that. So that's the way its informed consent means. And we discussed briefly about driving regulations. Yes, it's a legal framework. We can't overcome it. And in certain situations, we have to do post-mortem examination and discuss with the coroner because it's a legal requirement. With this knowledge in mind, we have to apply each and every scenario. Whatever scenario you're facing, there will be any one of those and then added something as well related to that. So then we can explain where the examiner asks about what are the legal issues in this case means, they can explain one by one. Going to the next slide, see Mental Capacity Act principles. So I said I will come back to the mental capacity in detail because in this act, first of all, presumption of capacity. If there is no reason to point out or to think about, there might be a lack of capacity. In this case, we have to assume the patient has capacity unless proved otherwise. See, the other way, just because a patient has a diagnosis of dementia, we can't say they lack capacity because the mental capacity is a decision specific. For one particular decision, they may lack mental capacity, but for the other decision, they may have mental capacity. And we need to take it decision by decision. And that's why we say we have to assume the patient has capacity unless proved otherwise. The next step is the support to make a decision. See, some people, let's say they're having difficulties. Sometimes the morning are not the good time. Mornings are not a good time for certain people. When they wake up, they become sleepy and tired, but as the day goes on, they become awake. So before making any important decisions clinically, we need to see, is there any other time, best time to discuss about this particular decision to this patient? There are exceptions in case of emergencies, but generally, if we can wait, we can wait to discuss about the best time. And that's what I meant. The support means think about the patient. And is there anything we can do with support to make the mental capacity better or the assessment better? Let's say they've got hard of hearing difficulties. Then rather than saying, okay, I say something and they ask, okay, they can't understand, they don't have mental capacity. That's not the way to do it. If we know they can't hear properly, and then we can assume different things. So checking with them hearing aid and then have the hearing aid. And then if they are doing a lip reading and then understand that, then go a little bit close to the patient and then show them the lip reading, and then they can read and then they can understand. So let's say people are finding it difficult. Let's say they've got a slurred speech and the understanding is difficult. Then we can think about whether any family can help with them because they might know better. And we are saying for the first time, we might not understand as a family do. So we can say, okay, do we need to discuss this and make a decision in front of the family? Let's say there is a language barrier. Somebody is not good at particular language. Let's say in UK, we speak English. And in those cases, we can say, do we need an interpreter to aid the decision or the discussion in this say? So these are all the things we need to make a support to make a decision. Without making those, we can't say patient lack mental capacity straight away. The third principle is ability to make unwise decisions. Again, just because people make unwise decisions, we can't say they lack mental capacity because it is allowed for people to make unwise. So we can explain different things and then the rationale and in detail, everything we can do. But at the end of the day, people can choose or not to choose a particular option and people can say no. The medical team or the doctors might think, oh, it's not right to refuse this particular form of treatment. but people have a choice. If they have mental capacity to refuse, they can refuse. And the last one is the least restrictive option. So when we say least restrictive option, let's say, for example, patient lack mental capacity, bedbound, and then having problems with incontinence. So immediately the next step is, oh, can we catheterize him? That shouldn't be there. We need to explore the other options. For example, getting the pads, and then can we manage with the pads, with the incontinence over there? And again, in terms of like a male patient, can we do help with the convene, like a catheter with the convene, without before catheterizing? And then the next step would be, okay, if all these fails or may not be possible clinically, then we can say, okay, unit catheterization is the best possible option for this particular patient. And if they lack mental capacity, we have to discuss with the team, like an MDG, and we have to discuss with the family to make the best interest decision. So when we make a best interest decision, we need to choose the least restrictive option. So I will whisk through again. Presumption of capacity. Assume patient has capacity unless proved otherwise. Second, we need to make every support to make a decision to understand from patient side. People can make unwise decisions. We have to allow that if we are sure that they have mental capacity. If we are choosing an option as a best interest decision when people lack mental capacity, we need to choose the least restrictive option. Right, assessment. How do we assess? There are four things. Again, when people are, if you're fond of mnemonic, you can even say URWC. Anything, you just in terms of whatever you want to remember, however you want to remember. So understand, first of all, any information you give. This is the key in any single consultation, whether it's a station 5 or station 2 or station 4, anything, it's a consent or procedure or anything. When we tell something information, we need to assess whether people can understand that. And how do we check whether they retain the information? So let's say we spoke something about yesterday. And then if you go and ask today, they say, oh, no clue, I've forgotten everything about it. Then we can question the decision at the time. That's a retaining the information. Then weigh up. It's not the weight up. Sorry, it's an error in spelling. It's a weigh up. When you say weigh up, the pros and cons. In situations like informed consent, we need to give them options, a plus, minus, option 1, option 2. So let's say we are going to do about the surgery. So what will happen if we do surgery? What will happen if we don't do surgery? What will happen if we do OGD, like a gastroscopy? What will happen if we don't do gastroscopy? And if we don't do, plus and minus. If we do it, plus and minus. So this we need to discuss. And then these things, people need to retain those information and weigh up against the balance. And the most important step in the mental capacity assessment, they have to communicate back to us all these things. And that's why any situations where, particularly, let's say in station 4, you explain certain things, and then at the end of the thing, you need to summarize. We summarize, and then in between, you have to check. Okay, what have we discussed in this consultation? Can you please let me know? And then they can tell. If we can conclude the consultation with a summary, with the discussion from the patient or the surrogate, with what they can understand and to communicate back, that's a full consultation or the complete consultation. So again, whizzing through mental capacity assessment, people need to understand, people need to retain the information, people need to weigh up against the balance of pros and cons, and then communicate back to us. Right, coming on to ethical principles. This as well, see, every ethical principle may not be applicable in all the scenarios. Unlike the legal, some legalities will be there, not the 4 things in ethical principles. But autonomy is always be there. Autonomy is patient's right. So we need to advocate for the patient's right. At the same time, we need to remember, if we link this to the legality, yes, patients have right to discuss about their health, and then discuss about the options. But unfortunately, they can't demand any treatment. And it's supported by law. So people can't ask, I want blood transfusion. If we think it may not be suitable, we can say no with clear explanation, sensitive way. But they can refuse treatment. So let's say we suggest, okay, blood transfusion is the best in this situation, or else you'll be more symptomatic and will deteriorate. And people can say, no, I know I can deteriorate to the level that even if the life is at risk, I don't want to have blood transfusion. People can say that. So autonomy means patient's right, but people have a right to know about their health, to discuss about their options and discuss about their treatment options and everything, but they have no right to demand any treatment. At the same time, they have a right to refuse treatment. Beneficence, second thing, is doing good. I think that's a base. Whatever we do, we need to do good. If you're going to do any harm, we are not going to do it. But nearly every single treatment or single medication which have effects and side effects, and that's why we need to get the balance. So when we tell the patient, we will say, yes, it's beneficial. It's not without any side effects, but in your situation, we feel based on our assessment and training and expertise, we think in this situation, it's more beneficial than you rather than the side effects. That's why we are offering. Similar thing, if you are saying we don't offer this treatment because the side effects or the harmful effects are more than the beneficial effect, that's what we are not offering. So beneficence is the key for any decision making. If it's going to be helpful, we need to offer. If it's not going to be helpful, no need to offer. And no need to ask the permission as well in terms of, let's say, for example, the blood transfusion is not appropriate. And we don't need to ask, what do you think about blood transfusion? Or don't ask, do you want blood transfusion? And most of the time, maybe by mistake or just reflex level, people ask in terms of CPR, what do you think? Do you want CPR to be done? Do you want resuscitation to be done or not? And I don't think that's the right way to put it to the patient, because if they say yes, if it's not appropriate, we get stuck. And then we need to go back and discuss, no, I'm sorry, it's not appropriate, we are not going to give it. So when something is not an option, don't go and ask the patient, what do you want it? But if there are two options, you can ask, say option one, this is there, option two, this is there, which one do you want to do? So both are same. I'm happy to do both the options. But if there is no option clinically, don't go to the patient and ask, do you want or not? And as we discussed before, patient has a right to refuse, but they don't have a right, unfortunately, to demand any treatment. Non-maleficence, again, do no harm or a less harm. So actually it's do no harm, but as I said before, any medication, any procedure, anything will have like a package of plus and minus. So we need to get the balance and then assess and then do less harm or no harm as much as possible. The last one is justice. Justice is keeping the resources, using the resources judiciously. And when we say judiciously, it's not a fairly. At the same time, we can prioritize depending upon the people's need. Say if there is a one bed and then there are two patients asking for, we need to prioritize. That doesn't mean we are ignoring the other. But there's one bed, two people, we have to make a decision in terms of prioritize the patient depending on the needs. And no need to, not no need, we can't and we shouldn't, we must not discriminate based on their history or anything. Let's say one patient is an IV drug abuser and then the other patient not. But as per the needs, if we need to give the bed for the IV drug abuser for treatment, we need to give. We shouldn't or we must not discriminate to say, okay, IV drug abuser, so I'm not giving bed to this person. Let me give the bed to the other person. We can't do that. So that's about the justice, using the resources properly. And in the public interest is more than like one particular, like one person or the family interest. For example, let's say in end-of-life care, patient is dying, imminently dying, and then if you're treating aggressively with the fluids and different things, see, that means, yes, we have got, let's say, 100 bags of saline, and then we are making use of 2 or 3 for this particular patient. If we go to the one patient, people can argue, okay, what's wrong in giving? That's going to make him happy, and then give the patient. First of all, whether it's going to make them happy or not, the other thing is, if it's clinically not needed, we are not going to give. And we are obliged to give proper explanation and convince the patient and make them understand that it is not going to be appropriate in this particular situation. It's not about making people happy, it's dividing the resources as well. Say similar thing, there might be another patient who definitely needs, let's say diarrhea, needs a fluid, and we are depriving another patient in the public interest and giving over-treating or treating aggressively when it is not absolutely needed. Don't take it in a different way and then assume we are not going to treat anything at all. It's not like that. If we treat when it's absolutely not essential, then that's where the justice comes into play. We need to choose the right treatment for the right patient at the right time, and not to do anything. We need to use the resources judiciously and with no discrimination. We need to be fair. We need to prioritize depending upon the need. All these comes into the justice. So autonomy to do with the patient right. We need to discuss with them, but they can't ask for any treatment or demand any treatment. They can refuse. Beneficence, doing good, that's the key. Non-Maleficence, not doing any harm, and then less harmful. If there are harmful effects or side effects, we need to get the balance. Justice, keeping the resources, using the resources judiciously, fairly, prioritizing patient, and public interest will be more than one particular person or one family interest. Right. We need to do a scenario to understand. So I don't want to complicate things with very complex scenarios. Just start with a simple one. 78-year-old Mr. Gary Thomas, admitted to hospital with shortness of breath and confusion. Clinically, was lower respiratory tract infection. So when I say lower respiratory tract infection, again, it might be like a crackling one of the base of the lung, or let's say the X-ray shows, anything you can say. It's confirmed. There's no doubt about it. Is it clinically or empirical? Nothing. It definitely, there is a lower respiratory tract infection. And antibiotics, need IV antibiotics. But at the same time, the patient wants to go home. What do you do? What are the legal implications here? What are the ethical implications here? I can give a few seconds if anyone wants to say or attempt. Right, okay. So first of all is the mental capacity, because the patient wants to go home. That's where we need to start. And it says patient is confused. So the first step is we need to assess the mental capacity, whether patient wants to go home or what basis he is saying. And with the treatment, does he understand that he needs a treatment? See, when he goes home, let's assume in the place where we are, we can't give intravenous antibiotics locally. The reason I'm telling this, there are some places in UK we can offer IV antibiotics at home, but not at all places. Let's say if we assume we can't give IV antibiotics, and that's what will happen. People will deteriorate. He will deteriorate due to the infection, due to the pneumonia. Then how we are going to tackle with this? First step, assessing mental capacity. We need to explain. And if the patient has capacity, and if the patient refuses at that particular point of time, then you can say, okay, they have a right to refuse treatment and they can go home. And even then, let's say it's about like a discharging against medical advice, we need to take every step morally to take care of the patient in the community. It's not like, okay, I say something, you're not listening to me, then I'm not taking care of you. That won't be the attitude for professionals. So that's one step ahead. We need to think in terms of, okay, this patient wants to go home. What can we do? If not IV, oral, and then anybody follow up in the community team. We can let the GP know, we can let the community district nurses team know, and then see how things go, what's going on. and then involve the family and make a decision over there, even if she says he wants to go home with the capacity. So in between, we will try all those things, explaining different things and explaining to the family. Can we get help from any family? Let's say if his wife or son or daughter wants to explain and really stay. These are all things, if he has some mental capacity, we can try different things. But let's say if he lacks mental capacity and he is confused, and if we think based upon our assessment, he can't understand, either he can't understand or he can understand, we think we can understand, or he thinks we can understand, but he can't rationalize, he can't retain the information, or let's say he could retain the information, but he didn't know anything about staying here, pneumonia severity and the risk of deterioration, even is a life-threatening situation, whether he understands everything or not. If he can't able to express everything, we have to say he lacks mental capacity at that point. Then if he lacks mental capacity, the next decision is best interest decision. The best interest decision is yes, as a team, first of all, and then involve the family, and people are very important to him. Then we can make a decision, okay, he will respond to the IV antibiotic mostly, but if he is going home, we can't give antibiotic, he will deteriorate. There is a risk of like a death as well in severe pneumonia. So we can make a decision in terms of, okay, we need to keep him here, and that's where the DoLS come into play as well. He lacks mental capacity, but we are keeping him in hospital against his wish in the best interest. So in that case, the DoLS will come in. We need to apply for the DoLS, and then we'll get a grant. They're all like an emergency DoLS. Just apply, we can retain for first 24 hours, and then we'll apply. And once people will assess, and we get a sanction for a week or so. That's there for DoLS. And the next scenario, before going on to the next scenario, any questions or any doubts? Maybe a few seconds. No, right? Okay, next one. Scenario 2. Again, in this scenario, you can have a read through. 67-year-old Emma Thompson admitted to hospital for abdominal pain due to end-stage pancreatic cancer. She was seen by palliative care team, started on syringe pump with the morphine, like over 24 hours, but she wants to go home. Also, she does not want a syringe pump. She has a mental capacity. Clinically, it's against medical advice. What do you do? Anyone wants to try and apply legal and ethical principle here? Right? Okay. As in the scenario, the first thing is about the mental capacity. It's clearly said she has mental capacity, so she can go home, provided she knows it's against medical advice. So what do we do? Do we just send her home, take off the pump, and then yes, you can go home? Can we do that? I don't think so. So even though people say yes, see, this is, I'm telling, when all the efforts have failed. Don't think it will be the first reaction to say, okay, what next? It won't be like that, because we will be explaining, and as I said, we'll involve the family, and then we will ask her concern about why she wants to go home and can we do anything more about it. Let's say she's missing the family, and can anything be done in terms of visiting? But obviously, sometimes it can't be done, because let's say with COVID-19 situation, it's difficult. The visiting regulations have changed, both in the hospital and anywhere else, in the nursing home setup. So this is what I mean to say legal. So even though we want to do it for the sake of like taking care of patients and the family, but when there's something legal, we can't do it. When there are regulations, we can't do it. The visiting regulations, we can't change. But if it was within the legal implications, within the legal framework, whatever we can do, we can try to do. That's why we need to ask why she wants to go home. Let's say she doesn't like a single room, and then we can change her to the bay if we can. Let's say the opposite is true. She doesn't like the bay, it's too noisy means, if possible, we can get the single room. So we can do all sorts of things, trying to keep her in because she needs it. But when all the efforts goes into like it's not effective or it's not promising, then we need to say, okay, we have to send her home because there's a clear refusal. And if she says, okay, I know what is what, then what do? Syringe pump is not there. And then when I say syringe pump, I didn't say the other reason, but let's say nausea and vomiting is there. If there are nausea and vomiting, and if you carry down the syringe pump, she can't take oral morphine, what do? We can think of patch. And this is what I say, like alternative options. Even though people are refusing our advice, the next possible advice we can say in terms of, okay, we can try the patch. Again, patch means we are talking in general. It can be either buprenorphine or fentanyl, depending upon the dose of morphine. Sometimes we can't give at all. Let's say she is on like a very minimal dose of morphine in the pump, and if we can't equate with the same dose of patch, we can't do it. All that I'm trying to say is, even though she's going against medical advice, we need to do whatever we can to make her symptom controlled to see how things go. And let's say she is going against medical advice. The next step is it's already seen by palliative care team that's in the hospital. We have to contact the palliative care team in the community and then let them know, because we are sending a patient. She doesn't want syringe pump. So we have taken it down. We have started on a patch, and please follow in the community. So here again, ethical principles. Yes, autonomy. Yes, they've got a right to refuse treatment. They've got a right about not staying in the hospital. Yes, provided she has a mental capacity. Beneficence, yes, we're doing good, but doing good as much as we can, because we can say is the best treatment is syringe pump, and the other thing may be less effective. But as a whole, and linking to the mental capacity as well, if people are making unwise decisions, we have to accept it and we have to support as much as we can. That's the second thing, beneficence. And then non-maleficence, and then do no harm. Yes, there are side effects, but again, we say if we go home, these things will happen. But if she says, I'm okay to accept the risk, but I do not want to stay in hospital, means yes, we have to accept it. And the last one, justice. Again, justice doesn't come here clearly in application, resources and other things. But if it's not applicable, you can say it's not applicable. And then prioritize the patient. We are prioritizing everything is rule. And that's what I said. Those three, autonomy, beneficence, non-maleficence, will be applicable in each and every situation. But justice may not be in all the situations. But if it is not applicable, don't tell in the exam just for the sake of addition. You can tell me, I don't think it's applicable in this scenario. Right. So that's all with the scenarios and the legal and ethical principles and how to apply practically in all the scenarios, which is going to appear in MRCP PACES exam. Anybody have any questions?
Hello, sir.
Mm-hmm.
I joined, sir, now. Sorry, sir. This case, last one, I want to ask the legal issues. In this case, will be capacity. The patient.
1 minute. I'll stop share. Yeah, okay. You tell me. Let it be, because we are discussing about the capacity. Yeah, tell me what capacity.
Will be capacity, and then LAMA, because patient wants to discharge against advice.
What is that? Against medical advice. What did you say?
Yes, sir. Discharge against medical advice. It is DAMA or LAMA, we can say, the legal issue here.
Okay. Yeah. See, discharge against medical advice. But my advice is not to use any abbreviations in exam.
Okay, sir. So discharge against, discharge against medical advice. It is a legal issue here. And the third, yes, a palliative treatment is a legal issue or not here?
See, I think you tell me.
You told before. Yes, sir. I remember you told. But in the books, it's written, and some mentors say palliative treatment is a legal issue.
No, see, when we say palliative treatment is a legal issue, it's all legal implication, isn't it? So why it's a legal issue? You tell me. Why palliative treatment? See, previously, I remember in the previous sessions, you were telling palliative care is a legal issue. So I told in terms of palliative care per se, see, palliative care, if you offer palliative, not only palliative care, anything. So are you mean to say, like, for example, care where the cardiology team is not legal? And
I got your point, sir. I got your point. It is not illegal in this. Just want to confirm this, yeah.
Mhm. So
Yes, in
that's
this
right.
case,
It's not about what team, it's about what we do. And
what we
then
do,
do we have any legal framework here?
what
Anywhere,
is applicable. Yes,
nephrology,
sir, so only, yeah. And sir,
nephrology,
the
any team, there is the legal implications to whatever we do, whatever treatment.
yeah, right, sir. Thank
Yeah.
you, sir.
You said palliative care treatment. Say any treatment which is linked to the legal issue, isn't it? Any treatment, say when we offer mental capacity. So we need to choose a treatment which is beneficial, and that's will come under ethical issue, beneficence. And then we need to choose a treatment which is not going to do more harm than the benefit. That's a non-maleficence. And the justice, we need to do the treatment by prioritizing a patient without discriminating or anything, or without giving more priority to the people. That's the three ethical issues come into play. Autonomy
Right.
is, yes, because people have a right to have that particular treatment for that particular problem. And legal is any treatment from our side. Yes, we are bound to give the most appropriate treatment, and we are bound to discuss as a team. And from patient side, it's legally, yes, they need to have mental capacity to accept the treatment. So anything treatment, two aspects. What we are giving, we are accepting. And then we have to link it. But don't go with the overall thing, and don't say the examiners, palliative care is a legal issue. I can't explain more than this actually with the palliative care.
Okay, sir. Thank you.
Okay, any other queries or questions?
Sir, one more question can I ask?
Mm-hmm.
Is there a warfarin treatment if we want to start on anticoagulant warfarin and patient is refusing till the end, then refusal of treatment will be a legal issue in that case?
See, well, it's a bit tricky because you've just come in, you've not seen the first part of the presentation.
Yes.
See, anything, refusal or anything, why they are refusing? So when they're refusing, is it linked to the mental capacity or not?
He has capacity.
No, I'm asking, refusal, is that linked to a mental capacity or not?
Yes, sir.
The mental capacity, is that a legal issue or not?
Yes, sir.
Yes, it is. Then the answer
So
is
it is already, yeah. Oh, yeah.
See, legal issue will be there in each and every situation because it's information sharing between a doctor and the patient, or like offering treatment or accepting treatment. The legal issue will be there in any situations. Tell me one situation where there's no legal issue.
Yes, sir. Yeah, I understand. It will be there. Capacity will be there. Confidentiality will mostly in most cases. It's like, sir, a consultant has decided to start warfarin, and we have to counsel patient to start warfarin, and we will tell all the side effects also, and to monitor INR, everything we told. Now the patient is refusing. He is not accepting warfarin. He has capacity. So capacity will be a issue, legal issue.
Yes.
But what about refusal of treatment? Is in books I've read that it is also a legal issue.
Oh no, the legal, see, the word issue is a problem here. When you say legal issue, I don't know what's the understanding is. See, the legal issue means that there is some big issue going on and that we need, it's not like that. See, when we see a scenario, when people ask about, is there any ethical issue here? Is there any legal issue here? Don't think there will be a big issue going on. So what are the legal implications we have to consider in this situation? What are the ethical framework we have to consider in this situation before making a decision? That's what the legal issue means. So if the patient is refusing, yes, refusal is a legal issue because it's related to mental capacity. Anything related to mental capacity is coming under legal framework. See, mental capacity is not ethical framework. Mental capacity, refusal is a legal framework. So when people ask about the legal issue, yes, it is. And that's what I said, each and every situation, there is a link to the mental capacity, irrespective of whether refusal or not. It's a legal issue. Comes in the legal framework. Okay?
Thank you, sir.
Way to PACES. The right way.
Right, we'll stop the slide and then just see for any more questions, the legal and ethical implications in a scenario. I'll give you last 10 seconds. Right. Okay. Thank you. See you all.